Hi class, my name is Sarah Laginus, and I decided to do my presentation on reducing maternal mortality in California. Before I get into this presentation, I wanted to state that I'm very passionate about this topic, as my sister Rebecca died shortly after giving birth to her twin daughters 2.5 years ago. So, what is maternal mortality? According to the World Health Organization, maternal mortality is the death of a woman while pregnant or within 42 days of termination of pregnancy, and it's irrespective of duration or time of pregnancy. It is from any cause related to or aggravated by pregnancy or its management, but it's not from accidental or incidental causes. Approximately 303,000 women die of pregnancy or childbirth-related causes every year around the world. On average, this means on a global scale, 830 mothers are dying every day. Most of these deaths do occur in developing countries, but the United States has the highest maternal mortality rate of any developed country. In fact, between 1990 and 2015, while the rest of the world saw an decrease in maternal mortality rates, the United States saw a 56% increase. They went from a maternal mortality rate of 16.9 deaths to 26.4 deaths per 100,000 live births. This is a terrifying statistic to me, and it leads me to believe that it's absolutely imperative that the United States gain a better understanding of maternal mortality and find a solution quickly. So California actually averages about 500,000 births in the state every year. And with that number, California accounts for 1 out of 8 births that occur nationwide. At the peak of its occurrence, maternal mortality reached 14 deaths per 100,000 live births in California within 2006 and 2008. During this time, California had the highest maternal mortality rate compared to any other state in the country. Luckily, though, due to the collective efforts of multiple organizations in the recent years, California has seen a decline in their maternal mortality rates from 14 deaths per 100,000 live births to the most reported 7.3 deaths per 100,000 live births as of 2013. While this is great change, there are still women dying of pregnancy and childbirth related causes every year in the state of California. And with the multitude of factors that contribute to maternal mortality and the rate, it's important we discuss each factor individually. Although maternal mortality does not discriminate against any race or age, there does exist disparities across racial and ethnic groups. Between 2011 and 2013, African American women had a maternal mortality rate of 26.4. Caucasian women had a maternal mortality rate of 7.9, Asian women at 7, and Hispanic women at the lowest rate of 4.9 in California. This latest reporting reveals that African American women had a maternal mortality rate 4 times higher than that of Caucasian women. Age is another factor that contributes to maternal mortality. Between 2011 and 2013, in California, women 40 years or older had a maternal mortality rate of 2.4. Women ranging between the ages of 35 and 39 had a rate of 10.4, and women ages ranging between 30 and 34, 25 and 29, 20 and 24 had rates of 6.9, 4.3, and 5.3 respectively. The maternal mortality rate of women over 40 was more than twice that of any other age group. Essentially, a woman is at an increased risk of dying during pregnancy or childbirth-related causes the older she becomes. Lastly, socioeconomic status and education level has played a role in California's maternal mortality rate. Pregnancy-related and childbirth-related deaths occurred more frequently among women who were, on average, poorer than the average woman giving birth in California. And this is also true for women who did not have a high school diploma compared to those who did. Many attempts have been made to examine these discrepancies among these factors, especially those related to race and ethnicity, but due to data source limitations, most researchers conclude that it is a multifaceted issue and no single intervention is going to reduce the discrepancies. Due to the expansiveness of maternal mortality, it has been difficult to govern laws and policies to protect women. With a number of factors that contribute to death during pregnancy and childbirth, there's no one-size-fits-all solution that can protect mothers from potential fatality. An effort that was put into place to allow for better identification of possible pregnancy-related deaths was in the 2003 revision of the United States Standard Death Certificate. This revision included the addition of a detailed pregnancy question on the cause of death section of the death certificate. And as shown on the image, this is what the standard pregnancy question looked like. In 2003, there were 21 states, including California, that had already offered a variation of the pregnancy question. But on California's death certificate, it only asks if the female was pregnant within the last year. It doesn't provide the specific data concerning whether the death occurred during the pregnancy, within 42 days of termination of pregnancy, or between 43 days to a year after pregnancy. The problem with the variation is it doesn't provide standardization that is needed when trying to collect data on maternal mortality. And while the increased questions on the 2003 revision of the U.S. Standard Death Certificate doesn't solve the issue of maternal mortality, it does allow researchers to have more accurate data to be able to identify maternal mortality within specific time frames. This data can be useful information to help determine how to solve this public issue. And as of 2014, all but 5 states were supplying pregnancy data for the standard 42-day time frame. Unfortunately, California is not one of them. A California death certificate still only provides the question regarding a pregnancy within 1 year after death or before death. When this spike of maternal mortality in California was noted in 2006, many agencies and foundations came together to not only question its occurrence, but also to find reasonable solutions. And it was through this collaboration that the California Maternal Quality Care Collaborative, also known as CMQCC, was born. It's a group of experts headquartered out of Stanford that are determined to end preventable morbidity, mortality, and racial disparities in California maternal care. This organization provides doctors and nurses with recommendations and toolkits to help improve procedures and safety protocols for OB emergencies. And according to the lead expert of the CMQCC, Dr. Elliot Main, these recommendations and toolkits are essentially emergency plans that detail advice on what to do in case of maternal emergency. And they include checklists of everything a delivery ward should have available, lessons learned, and addresses a range of issues doctors and nurses might experience during a delivery. And according to the organization's website, since its inception, California has seen a 55% decrease in maternal mortality between 2006 and 2013. This statistic has proven that these toolkits the CMQCC has provided are invaluable to expectant mothers. In finding ways to continue to decrease California's maternal mortality, I believe that California should begin conducting verbal autopsies and guaranteeing access to prenatal and postnatal care for pregnant women. The first alternative solution to reducing maternal mortality would be verbal autopsies. Verbal autopsies would be interviews and questionnaires completed by the medical team who took care of the women who died during their pregnancies and childbirth. This method of verbal autopsies would provide more personalized information The personalized interviews with medical staff who cared for these mothers could provide researchers with in-depth facts on how events transpired. Combining this data with the presently given statistical data from hospitals could highlight different ways doctors and staff can and should respond to dying mothers in order to save their lives. In India, they wanted to understand premature deaths that were happening. So the Million Death Study was conducted with an emphasis on verbal autopsies. They conducted verbal autopsies through structured interviews that included families' stories of symptoms and events that led to the death. And the outcome of the study, they found that the information was substantially altered, had substantially altered previous estimates of cause-specific mortality and risk factors in India. And the results of the study proves the significance of adopting their verbal autopsy method in order to shed more light on the causes and factors that contribute to specific women and their maternal mortality. As far as funding goes, the CMQCC, who already are conducting reviews of maternal deaths, could head this alternative solution. A con to this would be that reallocating money and resources within the CMQCC could be difficult depending on how their existing funds are, and maybe they wouldn't be able to stretch the organization's review capabilities to include these verbal autopsies. It could be a time-consuming process as well. And lastly, it would rely heavily on medical staff being able to remember specific details of an individual's pregnancy or delivery. And when these staff are seeing countless patients and performing many deliveries on a daily basis, it could be very hard to remember specific details. But on the other hand, this method can provide an increase in valuable data for the reviews that the CMQCC already conducts. It would allow for more personal stories to be shared in order to understand how one factor could compound upon another to lead to maternal death. In order to ensure that access to care is not a factor that contributes to maternal mortality, I believe that all expecting mothers should be provided with guaranteed prenatal and postnatal maternal care, no matter if a woman has insurance or not. With this method, I believe state and private funding would be the best option. An allocation of state taxes could provide funds necessary to pay for uninsured women to receive care, as well as private funders and foundations who focus on this issue could donate a portion of their resources to ensure women are given care. Also, OBGYNs could be offered incentives to take on mothers who lack insurance. The cons of this approach could be a costly one depending on the number of women who are uninsured at any given time, and women can abuse the system and elect not to be insured in order to take advantage of this offer. On the plus side, though, this approach does give all women ability to receive care, and it is care that could potentially be vital to saving a life. Canada is a country that has universal health care and provides physician-provided maternal care services. As of 2015, Canada's maternal mortality rate was 7 deaths per 100,000 live births, and this is a rate much lower than the United States. And while there's no research that currently associates their healthcare system and access to prenatal care to its lower rate, in Canada specifically, these numbers suggest that there may be some sort of correlation. And in knowing that prenatal and postnatal care increases the survival of women before, during, and after childbirth, there is importance in considering this option. In conclusion, women are still dying of pregnancy and childbirth-related causes in California. And it's African American women, older women, and women of low socioeconomic statuses that are at a higher risk of suffering from maternal mortality. While there will still be women who suffer unpreventable maternal death, alternative approaches such as verbal autopsies and guaranteed prenatal and postnatal care can aid in decreasing maternal mortality, not just in California, but nationwide. Society must act now so that families do not have to suffer from the heartache from losing their loved ones to preventable pregnancy and childbirth-related issues.